Okay, I am going to leave that door open because I think stragglers will continue to come in and we're going to fill this room. I'm going to think optimistically. So welcome. Thank you all for coming. My name is Tom Meehan. You may not see it, but I have 3 hats on today, and they all say primary care. I work for ProHealth Physicians, the largest primary care group in Connecticut. I also work for the Connecticut Center for Primary Care, which is a nonprofit organization dedicated to promoting and improving primary care. And lastly, I'm representing the Primary Care Coalition of Connecticut. So the coalition is a multi-stakeholder group that gets together on a regular basis to talk about topics that are of importance to primary care. So we are a co-sponsor of this conference. I had the privilege of working with others on the organizing committee for the conference, and we put together 4 different tracks. This is the first of 3 sessions in the primary care track. The other sessions in that track are one on health insurance literacy and the other on Project ECHO. Project ECHO is a mechanism for distance learning. It's case-based, and several organizations in the state are active with that. But this session I'm really excited about. I had the pleasure of working with the panel on a project involving the topic at ProHealth right now, but they're going to talk about that project as well as other work that they've done in this area. So it's a long name, and let me get it right in terms of the title of the session. Connected Devices, Artificial Intelligence, and Virtual Care, Innovating with Technology and Care Delivery to Help Patients better self-manage diabetes. So that's the topic on diabetes, but certainly the things that they're going to talk about apply to self-management of other chronic conditions as well. So I'm going to start with introducing Karen G., who will basically, this is a panel session, and Karen will moderate the panel. So Karen came to ProHealth about 2 years ago. It's been a pleasure working with her over that time. She's a senior VP, and she heads up our statewide multi-specialty IPA. With that, I'll turn it over to Karen.
Thank you, Tom. Well, welcome, everyone. I'm really excited to be part of this session today. I'm certainly a non-clinician, but where I see the opportunity when you're working with connected care, now we're using tools that people are very familiar with, and it's also an opportunity to support our providers, because when I'm out there talking to physicians, what I hear a lot is we need more support. As you move to value-based care, I think as all of you know, it does require... Great, thank you. It does require quite a bit more work, and the physicians are asking us, we need more support in our offices, especially when we're working with patients with chronically ill illnesses such as type 2 diabetes. So I certainly see this as an opportunity to provide better support to the doctors so they have more time to see other patients and also really to kind of talk to the patients. The other advantage when you're working with this type of connected care model is we have a lot more timely data because we're getting real data feeds that we can provide back to the doctor. And when you're dealing with this type of illness, a lot of times you have to wait for the patient to come in. And they may miss an appointment, and you're not going to have that information that's available to you. I think part of it is also to kind of what I would call data integrity. I mean, I hear a lot from the doctors when the patients come in. If you think about it, they may forget to tell the physician something. But now with the data that we have, we're able to gather with the program that this esteemed panel of speakers will talk about, I think we're really going to be able to change the market and really start to engage the patients. And you'll hear about it in some of the tools that they're describing, how we're really bringing the patients in to be part of their health care. So with that, I like to introduce or let the panel introduce themselves. Directly next to me, I have Chrissy Norton, and then Kevin Delory from LARC, and then Dr. Laura Gandridge. So Chrissy, I'll start with you.
Good morning. My name is Christy Norton. Sitting on the panel is one of the members that's helped to develop the program that we'll talk about today. I sit within United Health Group Research and Development. So it's a team that really focuses on transformational innovation. So how do we look out at what's coming in the marketplace and look ahead and where we need to be going? So the work that we're going to talk about today, we've been focused on kind of the connected care space as an organization for, the last 3 to 5 years. And so the program WellHop that we'll kind of dig into really builds on learnings that we've done. And we'll talk about the work we did with Dr. Laura Gandrud with Children's Hospital in type 1 diabetes. We have some work that's finishing right now with Northwestern University in the asthma space, but really it's that premise of how do you hover over patients as kind of this device information is moving from the wellness space into the clinical space. How do you take that information and provide it to providers in more of real time? And really the focus is the right data at the right time because, there's so much information coming in and providers are extremely busy, but they do want that information to help to inform care decisions. So I've been with United for the last 8 years, and I've really been focused that entire time in taking those early stage innovations and moving them to scale. And that scale would be whether or not it scales into our organization, United Health Group, so whether that's United Healthcare or Optum, or whether it scales out into the marketplace depending on the program and what's best for the industry.
Great. I'll use this one. Good morning. My name's Kevin Delury, and I head up operations for LARC. LARC is a wellness and disease management digital platform for patients. Our mission is care and compassion for all, and so those are both very important components of what we do. So our approach as a digital platform is not to present the better dashboard and the better chart, which I think a lot of companies in that space, that's what they do. What we do is use conversational artificial intelligence to provide real-time coaching and guidance to members with chronic conditions such as diabetes. What we'll do is we'll take data from connected devices such as a glucometer, a fitness tracker, the phone itself, which has a lot of sensors on it, and we'll take those real-time data insights and convert that into a meaningful conversation to the user about what they're experiencing in their day-to-day interaction with their disease state. So, for example, an out-of-range glucose reading, we'll be able to tie back to perhaps a sugary meal in the morning and a little less activity than they normally do. We'll be able to take long-term trends to see how behaviors over time are changing those health outcomes. At the core, compassion is essential to what we do. So in those conversations through LARC, we are focused on emotional well-being as a core component because anyone who's trying to take charge of their disease state knows that the emotional challenge of changing your behavior is really difficult to take on. And so we want to be that support mechanism to let someone know that they're supported in that journey. So our focus is so consumer-centric and patient-centric, but the benefits are that Christy talked about is we have an abundance of real-time data of what's going on in that user experience, and in this particular pilot we're discussing, we're able to pass that information along to the physicians and the care center in a way that allows them to interact clinically where appropriate based on that real-time data. So I look forward to talking about this a little more.
Hi, I'm Laura Gandrud. I'm a pediatric endocrinologist at Children's Minnesota, and I work with a lot of children and teens with diabetes, primarily type 1 diabetes, which is a disorder in which the pancreas is not making enough insulin or doesn't make insulin, which is similar to but not type 2 diabetes, which comes from a resistance to insulin, so the body's not making enough insulin. It's resistant to insulin in terms of maintaining blood sugar. So we, in the type 1 diabetes world, there's a lot of data. We have so much data being generated. We have a lot of connected devices now, but we really don't have connected healthcare. And in trying to help our teens with type 1 diabetes who are so technology savvy, we are trying to think about ways in which we can bring that data into our daily practice. How can we help the teens? How can we be with them outside of the walls of the office itself? I'll see a patient in clinic and I feel like one of my roles, the burden of this disease is so high, and one of my roles is to be there and give them a pat on the back and say, keep doing this, you're doing a great job of doing this, you can do this. And then I'll see them back 3 months later. and they'll share with me that, oh, things went great for the first 2 weeks, but then everything fell apart, you know, and I wish I could be with them at that time when they're having a tough day, to be there to give them the pat on the back. So I think that we see this opportunity of connected devices as a great one, especially for people with diabetes, to be there to help them and provide compassion. So that's how I got involved in this panel.
Thank you. And, given your experience, Dr. Andrews, what was it like, and how did you engage the patients when it came to remote patient monitoring? Can you tell us a little bit about your experience, the challenges, and the outcomes related to that?
Yeah, exactly. So we, because of all these connected devices now, we have pumps, we have meters, we have sensors. We really were of the same mindset as the group at United Health Group in terms of how can we use that data to go beyond the walls of the office to help our children. So what we did is we collected data from their meters, pumps, and sensors, and actually had a team put together where we were looking at that data weekly. So how can we be more timely in helping those patients deal with a new sport where they have new insulin needs or new glucose patterns? So we went from being in contact quarterly in the clinic to being in contact weekly. So that was addressing the challenge of really infrequent data assessment, and also dealing with the challenge of infrequent support for them, just really kind of emotional support, compassion, and encouragement. So it was helpful. So for 6 months, we were communicating on a weekly basis after looking at their data.
Great. And what excited me about this WellHop project is, I've been involved in remote patient monitoring before, but it's now with the addition of an app that's based on artificial intelligence. So, Kevin, would you like to tell us a little bit more about that?
Yeah, sure. I don't know if we can pull up probably a slide that shows, because it's a little hard to describe. So, yeah, perfect. So I mentioned what we use in terms of artificial intelligence. You hear artificial intelligence in healthcare all the time, and you're thinking of Watson and, these, we're going to, throw millions of claims and data points in, and we're going to do better diagnostics and all that stuff. And that's not a lark. We are, as I mentioned, patient-centric. And so what you see up there is the actual conversational artificial intelligence, where the white chat bubbles are actually our artificial intelligence, and the green is the patient conversation back. And where we leverage the artificial intelligence is really in trying to better decipher what the patients are going to find useful, interesting, and engaging about the data that they have, so that they can keep engaged in their own behavior change patterns, right? We're not going to be able to solve these problems, in a day, right? This is long-term lifestyle change and behavior change. And so we want to have a dynamic interaction with a patient that allows them to get something interesting and useful in every one of those interactions. So when they're coming in, they're essentially getting that coaching session that says, here's a piece of data we saw, here's how this relates to trend lines of what you've had over time. And then we layer in things like cognitive behavioral therapy that gives positive reinforcement for the positive choices they've had that relates to what those trend lines are. And so I think you can see some element of that back and forth. So that's our primary design. And
I would just add one thing, because LARC for me was a little difficult to wrap my head around. So think phone app. You're talking to a bot. So you're having a text conversation and getting educational content, you're getting reaction to how your day's going, it feels like you're talking to a person. In fact, we had a patient that wanted to know, had a conversation with the CDE, the Certified Diabetes Educator, and wanted to know, are you the person that I've been texting back and forth? No. But it's just, so think phone app, you download it, and you're getting this conversation back and using AI, so it's really based on what you're putting into the system. And that, I think, is what is so unique about LARC.
Absolutely. And so one thing with that is because of this on-demand chatbot experience, it's 24/7, 365, as much as you want, and infinitely scalable. So we can go to 1 million patients tomorrow, and it doesn't we don't have to ramp up a team to do it. It's all there, and that experience is incredibly personal because it is using that personal data for what those conversations are. So I'm not sure we're 100% Turing test, but we definitely get people, like Christy mentioned, who want to know. We'll do user feedback sessions all the time, and they'll ask, which one of you is the one texting me? We get that all the time.
It's great.
So, Christy, with the guidance of Dr. Gandry using the LARC app, tell us a little bit about WellHop.
Sure. And Sarah, if you want to pull open, we get visual, I'm super visual, so we did bring a slide that kind of explains. So contact setting, so Dr. Laura Gandrud worked with us around the type 1 work. And we learned a ton, published on that, because of course everything needs to be evidence-based. And then, as Laura's an early adopter, she was willing with her team to be the one interacting back and forth with the patient. And as she mentioned, they were doing that weekly. And the model worked. And we thought, okay, now as we move up the maturity model and look at scale, not every provider is going to have the time to take their team and do that interaction. So what's unique now is we talk about WellHop. And to give you context, WellHop is a branding name. So it's a play on bellhop, which is concierge service. So WellHop is concierge service for healthcare. So when you think about WellHop, what we've done is we've built a virtual care center team. So it's not the primary care physician. It's a team that we've built in the ProHealth corporate office. And you can see in the middle of the slide, so we have a success manager. So that's an engagement specialist. Think of that as a non-clinical role, helping people enroll, helping them with their devices, anything they need, scheduling appointments. Then we have 2 certified diabetes educators that are care coaches, and they are interacting with the patients and, setting goals, reacting to data that's coming across on a daily basis. We have Dr. Tom Meehan, who mentioned in the beginning that he has several roles. He is the physician that is overseeing this team and is providing an escalation point for the care coaches. And then we have a pharmacist who's really getting in and looking at the medication for the patients. So that team is self-contained, but is partnering with the primary care physician. So if you start on the left of the slide, you're going to see that we have devices. So all patients that are enrolled in this pilot are type 2 diabetics. And then working with their PCP, we have put them into one of 3 programs. So if they are focused on A1C, if that is their target at the time, then they're working with a blood glucose meter. If they are working on hypertension, being type 2 diabetic, then they have a blood pressure cuff. And then finally, we have a set of patients that are working on BMI. So they are receiving a scale. So they, for the pilot, have 1 device. Future state, you could see that they would have multiple, but when we think of behavior change, we didn't want to bring all the devices at once. So a single device based on the clinical outcome they're working on, along with the LARC phone app. All of that data goes into the virtual care center daily through a connection, they called an API in tech terms, that connects LARC with our coaching platform. So we're on an Optum coaching platform that really brings all the care plans at the fingertips of the care coaches. So what the care team is doing is, I would say, twofold. They are scheduling calls and reaching out with patients and doing behavioral coaching. And then they're also reacting to tiered notifications that are coming in from the data. So data that's trending really high or really low. And so they can have those educational conversations. So, sitting in the virtual care center, I've heard the conversation, of the patient trending high blood glucose. They call into the virtual care center because they get a notification in LARC. Or we do the outreach because we get the notification as well. And the coach can have the conversation about what was happening that led to that high reading. The 3 pieces of pizza. And what do you do differently next time? Is it 2 pieces and a walk? So they can have those educational conversations about how you have more time and range. So they're monitoring daily. Then I would say what's unique is we have added the primary care physician into the model. Virtual Care Center is fully integrated, so we have access to the electronic health record, we know when the patients are coming in, and we're providing a summary, so a patient progress report. So a patient that's coming in, they still do their quarterly visits with their PCP at ProHealth, and the PCP will sit down and say, here's what's been happening between your visit. And in the past, they haven't had that visibility. So in the patient progress report, we have the data device information that comes in and is summarized by the team. We have a narrative of what's been happening in between with those coaching calls, as well as the data that we get from LARC. So the patient that's inputting food, activity, sleep, med adherence. So it's data that hasn't been available unless you're having a conversation with the patient and they brought in a detailed journal. So we're excited, and what I would also add is when you think about this, we've talked about type 1 diabetes, we talked about asthma, right now we're focused on type 2, but the end goal would be that we treat the full patient, regardless of condition, using that device data with a team hovering over to provide care.
And I would just like to make a point that one of the findings from our study was we had no issues enrolling patients. You know, they were excited about the extra support. Everyone, the children, the family, you know, to have this is a unique opportunity to step outside the office and have this ongoing support. And also, which I think will be the case with WellHop, is that the other physicians that I worked with really enjoyed it as well. They knew that they were doing an office visit with their patient and making changes, and someone would be looking at that a number of days later. So I think it's a nice integration of quarterly care with the ongoing daily care, which is super helpful. And you mentioned the timely data. You know, if someone had 3 pieces of pizza 2.5 months before their visit, they're never going to remember what did you have that day that your blood sugar went so high. So it really increases the value of the education when it's that timely.
Dr. Gadry, following up on that, from what you now understand with what we're doing here with the WellHop, what are some learnings you might suggest based on the pilot that you had in type 1?
Yeah, I think that LARC is the absolute complement to the clinical care that we were providing, because what we found was a lot of the input that we were providing to families and children regarding their insulin doses was helpful, but what they really needed was someone to help engage them in their care. It wasn't just the medication. I think that it's very complementary to have these two services, the LARC along with the care coaches embedded with the physicians. So that at that point we didn't have an engagement specialist essentially who could provide that help. The other thing is the way in which the communication occurs. You know, I feel like this is back in the dark ages. We communicated with our families via email. And we had to send them text messages to remind them to look at their email, because a lot of times the data wasn't getting to the patient or the recommendations or our encouragement. So I think that, this is a much better platform, and that it's really easily interactive for all ages.
That's great. Kevin, because we've had this pilot up and running now for about 6 weeks, and we've received a lot of feedback from our virtual care center team members, as well as the patients. And, Kevin, I know you've heard some of that feedback. What are your thoughts around it?
Yeah, so LARC is designed, and again, it's very patient-centric. So it operates both as a standalone, but the point of this pilot is to feed into the broader healthcare ecosystem, right? So that real-time data can have some actionable clinical follow-up, right? But you don't want the patient to know that that's necessarily what you're doing, right? So the challenge with LARC and with anyone when it comes to engagement, right, is what are you providing in value in a daily interaction that drives a patient to make a choice to say, I'm going to choose to take some % of my time to interact with this thing, right? And that is the challenge, across every condition everywhere, right? Is how do you get people to take an active role in their health and make the choice to do that. And so having that interaction be engaging and useful is really important. So one of the things that we've, I think, heard good feedback on is one of the things that LARC will do is as we pull in that data, so data from devices around things like activity or sleep patterns, or seeing what those glucose readings are, we'll do proactive, we call them nudges, but we do basically your little notification center on the phone that, will acknowledge that something has happened and it's worth, popping in and having a conversation. And so that's a driver, an engagement driver to go in and have that conversation. But then you have to follow it up in the application to say that the patient knows that when they go in and follow up, they're going to get something interesting, right? They're going to get something that's insightful. They're going to see that, oh gosh, I had 2 hours less sleep, and it's really having an impact on some of my readings today. And so, I need to make sure I'm planning, a good night's sleep if I can. And then, I think following on to how it feeds into the clinical side, we've in healthcare, we've obviously the last 10 years, there's been a lot of movement towards data, and the problem is not necessarily that we don't have data, but we have useful data, right? Any physician in here, I'm sure, is overwhelmed by the amount of possible data you can look at, but you're not going to spend your time parsing out the things that are useful. And so, LARC as a platform, we are very agnostic in terms of we're not going to be the ones who tell you this is the data you need to see. But what we're going to do is we're going to feed into your existing systems and allow, the physicians and the teams that are designing these reports to think about what's actually interesting, insightful, and, succinct that a physician is not spending their time, looking for those carve-outs of useful information. It's going to be presented there so that they know, the 3 pizza example, that's the 4th day this week they've had that meal. This is the conversation I need to have when my patient comes in next week for my appointment. And so tying those things together, I think, has really been interesting to see how it really does kind of close some of these gaps in terms of the physician care.
Thank you.
I would just add one other thing. When we started having conversations with leaders at ProHealth quite a while ago, taking the learnings from what we did with Type 1, the message as we had provider conversations is that the education piece is what was missing. So the patient comes in for their quarterly visit and they have their 15-minute appointment, and there are so many things that need to be covered, and behavior change is really hard. The providers felt like they're saying the same message over and over, and they're not seeing change with their patients. So when we started looking at what we were going to build and looking at partners, we were really looking at, there's a lot of companies that will do device aggregation, but what we wanted to do is really bring in the educational component and have it be more in that daily interaction, and that would be the piece that I think is critical for patients to make that change. So they're having conversations with the coaches, but it's also being reinforced, and they're getting the educational pieces with LARC that's using the AI to adjust. And would you just talk a little bit, because we haven't really hit on it, just some of the what you call missions.
Yeah.
Some of the different educational components that come through in the app for the patient?
Yeah. So we layer the real time, and I've talked a lot about the real time aspect of LARC, taking that real time data to have a conversation. But then we also do educational tracks. So we have kind of weekly topics that we focus in on, spanning all sorts of behavior change as it relates to disease states. So, you might have a mission where this week it's carb and carb control. And what we're going to do is when we have conversations as people log meals, we're going to really hone in on what you're making choices around carbs, and then tying it back to the data we have to say, we talked about, carbs in the morning and the impact that can have, throughout the day on your glucose control. And we can see your readings from the day, and you had a bagel for breakfast. So let's tie that education together with kind of what you're experiencing in real time. And so we have usually somewhere between 26 and 35 odd weeks worth of educational content in all of our programs related to that specific disease state. One other thing I just wanted to mention when you talk about learnings, one thing that I think is somewhat counterintuitive to some people, but once you think about it, it makes a lot of sense, is the demographics of engagement, where I think there's a perception that you throw out a word like artificial intelligence in an app, and it sounds all very like tech heavy, and so there's this concept that says, gosh, this is a millennial product, right? This is all the people who know how to use apps and are really very. What we see in the data is it's actually a little counter to that. It's tends to be older. So where we see our highest engagement rates tend to be in the 60 and over population. And a lot of that, I believe, is because at its core, it's a text platform, so it's texting, which is a fairly low barrier in terms of technology, and it really is heavy on that kind of compassionate and real-time emotional support. And so I think that resonates very well in a population where behavior change is difficult in that population. So.
Yeah, it's interesting. I'd also add, before we embarked on this, as Chrissy said, we spent a lot of time prepping, and that included educating as well as selecting the physicians. And a lot of it's not just the patient education, but the provider education as well. So I don't know if you could talk a little bit about that, Chrissy, and also Dr. Gadget, from the physician perspective to adapt something like artificial intelligence.
Yeah, so one thing I would highlight, so when you think back to the work we did originally with type 1, I remember going in when we did an office visit, and Laura was kind enough to have us come in and kind of show us the facility. And there was a back room that had all of these computers and tons of cords. I mean, I wish I brought a picture. Unbelievable, because of all the patients that bring in their unique gadget that, Laura's team has to download the data and print out one of, I don't know how many different reports, depending on the vendor. And then in that appointment has to realize, how do I interpret the information from this group? So what we took from that is, we really needed the program, when we think of WellHop, to have a single source of truth document that the providers fed into. So, we established a clinical team, and, Dr. Meehan and Dr. Gandrud both sat on that team, as well as providers from ProHealth that were giving us feedback on what we were building. So we've spent a lot of time, because we know if we build it and it doesn't work into the workflow, it doesn't matter because it won't get done. So we've spent a lot of time at the offices that we're partnering with, and they give us ongoing feedback. So, they've been willing to participate in interviews to give qualitative feedback. We've been meeting with them monthly. They're tasking us through the EHR when they have conversations with patients. So, we can have someone opt out if they've had that conversation. And they really are truly partners. So when I take, for example, how we're doing the engagement, we felt confident we could get people enrolled. The harder part is getting them to stay engaged for the duration and look towards the outcomes. So we built a marketing plan, and they're heavily involved. So when you think of the patients right now that are eligible at ProHealth, they go into their provider, and the provider has a conversation in the office with them about the program. They hand them a piece of paper that, here's everything you need to know about the program, that has the website. They have people on their team that have tablets that are sitting down with patients and showing the video and saying, you can enroll right now. It's about a 3-minute process online to enroll in the program. And, if that doesn't work, then we are sending a letter to the home that's from their physician. So you can imagine that's been developed with the physician. They feel confident in the program. And then we're calling from the virtual care center that's ProHealth staff. So it's closed loop care. It's 100% integrated into the ProHealth team, and it's endorsed by their physicians, which we really felt was critical. Anything either of you would add?
Yeah, I've just appreciated the integration with the clinic. I mean, it's there again. There's so many connected devices, but actually really integrating that data in a way that's acceptable to physicians and a physician's schedule is key. And that haven't seen that being done yet in a diabetes climate or environment. So,
yeah. And when you think about the engagement pieces, one of the early learnings is, it's easy to enroll. You get your device. That may be, for some, a little more difficult to sync up with Bluetooth. So we're working with Best Buy Geek Squad, so we would have escalation. We don't want the technology to get in the way. But even just being able to give nudges. So I think one of the key learnings, Lark gives those nudges, but we found, in some cases, people maybe even need a help beyond Lark, a nudge. So we have the care coaches who can watch, and we get alerts if someone hasn't been active for X amount of days. We can do an outreach call. And they say, oh, I didn't know I was supposed to use my device yet. I thought I was waiting for our first call. We're all of these great learnings when you can do those real-time conversations with patients.
And I seem to I have a tendency to always jump to the outcomes. So, Christy was telling me, slow down, we got to figure out how to engage the patients and the physicians first. But, I'm still somewhat outcomes focused. So, Dr. Gadger, I'd ask you, since you already done the pilot without this type of application, what were some of the outcomes that you saw in terms of the health improvement?
So we saw improvement in the hemoglobin A1C. So we had a group of patients who were getting the weekly outreach and a group of patients who weren't getting the weekly outreach. And there was an improvement in the A1C over that period of time. The biggest improvement was with those children who were routinely uploading, so the more engaged patients had a better improvement in A1C. And then we actually saw that the adolescents, so we had a group of 8 to 12-year-olds and then 13 to 17. And it was actually the adolescents who had the biggest improvement. And that was really great to see, because it's the adolescent group who historically has the worst glycemic control or control of their diabetes when you look at a population, from the youngest to the oldest. The most difficult population to help has been the teenagers. So that was really promising to see that improvement. The other thing that we did is we did diabetes-related quality of life measures, and we found that there was a clinically significant improvement in quality of life with this intervention. And that matches with the anecdotal data that we got, where families at the end of 6 months were like, what? You mean it's over? They were really disappointed to not have that ongoing support anymore. So that was really encouraging as well. Like I mentioned, it was very readily accepted by teens, by families, by the physicians, and that showed through in the quality of life, which I really feel like that, looking at patient-recorded outcome measures is important. And if we can move that quality of life, then we're going in the right direction.
Excellent point. Thank you. So, Christy, how do you think we're doing?
As Karen mentioned, we opened enrollment about 6 weeks ago. So we have about 150 people that are enrolled in the pilot. Overwhelming success from people that are interested. I would say one of the challenges for some has been access to a smartphone. So when you think about the pilot, if you are receiving care at ProHealth at one of the offices participating, over age 18, but you do need a smartphone. So we'll have to dig into that more and determine, if in the future we would provide smartphones, but for the pilot, we did have that limitation. I think it's going fabulous. We have care coaches interacting. We have what is fun for me to participate in a daily clinical huddle where the care coaches get to bring forward, cases to the physician to have conversations. And things have come up from those first phone calls with patients of, I'm not taking my hypertension medication. Oh, there's a conversation of why it's important, and let's figure out, is it side effects? So those are examples. Then you think about it, we escalate internally in the virtual care center, and then if needed, we're going to the PCP. So we really want to keep the burden on the virtual care center team. That's why there's a clinical team that is engaged in the pilot. We really are not trying to have this be, we're going to uncover things and then put it back on the provider. Because we're partnering with them, and that's why we built a physician into the model. So I would say it's been positive. We're excited where we're going at this point. We're looking to enroll up to 400, which is we put a cap at the top, and if we get there, we will close, which there is a chance, but we're excited about where it's headed right now. Yeah.
So, Kevin, from these learnings and what you're doing in other areas, I guess, what do you see this trending? I mean, right now it's still somewhat early. Mm-hmm. What would you like to see it evolve to?
In terms of the model or the product?
The model and the product.
So a couple things we're doing right that I think I would really want to, through the model, we're gonna figure out the right touch, which is that meaningful data in a format that's useful, that's not a barrier to that physician or care center interaction, right? So again, this goes back to the earlier point. We have we at Lark have a tremendous amount of data. Like, we have literally thousands of activity data points per day per patient, right? And no physician wants that level of detail, right? So it's finding a way to share that data that really becomes insightful, useful, and ultimately, leads to those meaningful physician conversations, and also knowing the right point to intervene. So, is the right point to intervene 3 days of non-activity or 7 days? Like, how do you figure out those right kind of key engagement points? Because this is a long haul project, right? And so you got to find that balance of not being badgering, but also not ignoring patient needs. So I think that's important. On the product side, so with Lark, we are really fascinated to see the feedback that comes from patients, because one of the things I mentioned, with artificial intelligence, we're continuing to serve up conversations that the AI believes is the most useful and engaging. But getting the real patient feedback, is going to be useful for us. So I'm really excited to see the patient, what they have to say about that experience. And it is interesting. I love, it always comes down to the patient. And I love when you hear the things of, was that you texting me on the other side? I love hearing that kind of, because it means that person thought there was literally someone sitting there 24/7, sitting on the other side of a phone, constantly ready to answer their question. And that's, to me, like the best compliment of what, an engaging experience would be like. So.
Right, thank you. Dr. Gadge, how would you see using this type of technology now in your pilot? What are the opportunities?
Oh, I want to use it for all of our patients. I mean, I think that wellness is applicable to anyone that you're caring for. Everyone has a goal or something that they want to achieve in this, whether it's increasing activity level, exercise, making healthy choices, eating, losing weight, improving blood pressure, improving A1C, reducing low blood sugars. There can be all sorts of goals that can be supported by this type of platform. So I've been trying to talk to Kevin about, well, can we do a pilot on this group of my patients? And how about these patients? Can I get them signed up? So I think that's what's the beauty of the platform is the compassion perspective of it, which I really like, the constant interactions, the help with engagement and so forth. So I really see that the clinical applications of this is really huge. And what I'm most excited, I'm very excited about the platform. I'm really excited about this pilot with the integration with the office and the physicians and the primary caregivers or care physicians, because like I said, we need to find a way to seamlessly integrate all of this data into our practices. We must, and me getting 20, 30 days of Fitbit data on 1,800 patients is not effective. Right. So it's exciting. I think this is really, I can't wait to see where we are in 5-10 years.
Yeah, me neither. So Christy, what's your vision for this?
So when we talk about this as a team at UHG-R&D, it's really, the vision is scale. Because we do see, as Dr. Gandru talked about, that this is the direction we need to head, that it needs to happen. So thank you, Sarah. So we do have, when we look at the pilot, we do have some things we're looking at. First would be, did patients enroll and did they stay engaged? So this is a different model of care. Do patients want more care? So we're testing that. And then if they do, you can see that we will look at outcomes. It's a 6-month pilot at this point. So we'll be looking at the data to be trending. We're looking at patient and provider satisfaction. How does the model fit into the workflow, and do the patients want this? And then, of course, we're looking at operations. So we talk a lot about the program. It's kind of a menu of options. So for the pilot, we are giving lots of options, and we're not dictating what patients need to do. For some, they may only interact with the care coach. For others, they may say, I don't want to talk to the care coach, I want the device and LARC. So we're really, at the end, we'll be measuring which of the kind of the menu of all the different program offerings made a difference with outcomes. Because when you do this early stage innovation, it has to be evidence-based, but not everything scales. You know, it doesn't make sense. You may learn that you offered something and you say, you know what, that didn't really change the outcomes. People weren't excited about it. We don't need to move that forward into kind of the next phased approach. So we're excited. The piece that I haven't highlighted yet is we are also partnering with Northwestern University, so kind of our academic partner, that we have a third party that's coming in to help us evaluate at the end the program. And we've worked with them, longstanding partners kind of in the diabetes space, as we did similar work on virtual diabetes prevention program that's now scaled nationwide. Yeah, so exciting. I mean, we're very excited in where this is headed.
Thank you. You know, I have other questions, but I would also like to invite some questions for the audience, if you have any. Yes, in back.
Hi, my name is Linda Crickle. I work at Qualidan, and I'm a certified diabetes educator. This sounds like a really exciting program. I just have two questions. One is about the social support piece. So kind of piggybacking on Dr. Ryder's talk today, when you encounter people that have various social determinants of health, how do you handle that? And then also, my second question is, we know from research that a combination of one-to-one and group is really what yields the best outcomes. And that research is a little bit older, and we haven't had any more recently. But I know in my practice, people who do the best have family members involved or caregivers. They learn and they embrace and they support the person. So I'm just wondering how that is incorporated. And if there isn't a plan for that, I've got some thoughts to share with you.
That's great. That's great.
Thank you.
So I can kick it off and then pass it to you, Kevin. We've been talking about that. So I love that you're a CDE. We looked long and hard because we thought it was really important to have certified diabetes educators and that level of expertise in the virtual care center. You know, Karen talked briefly of all the prep that led up to kind of the go live date. And one of the things we did look at really would be community resources and what other resources would be available in the area for patients. So we do kind of have a listing depending on where the patient lives. And we've built the team in a way that we feel they are not 100% dedicated to interacting with patients because we know things will come up and we will learn. So it allows us a little bit of space as new situations come up with patients and we need to solve and say, what are the resources available? How would we build this into the model that would become scalable? So we've got that in mind and know that there's more work to be done. And we just talked about it a little bit at dinner last night. And do you want to comment from a LARC perspective?
Sure. Yeah. So great points and very, very in line exactly what we've been talking about the last 24 hours internally. So from a product perspective, we are looking at a few different things that are on our roadmap to build out. So one of them is the social component, finding those. And we're still very early in our design because we want to be very thoughtful in how we do this. We're probably not going the peer group way, but more trusted advocates within your own life. So family members, close friends, people who know that you're on this journey and who are going to be your support system. And then potentially also layering in, a physician element there of, who's your primary or whoever it is in your kind of clinical network that would want to see your progress as well as be able to, come back to you directly through the application to say, hey, I saw you achieved this. That's awesome. And then the nice thing for us from a technology perspective is we can automate the circumstances in which those messages come back, so it doesn't actually necessarily require a physician to write an email through the platform, but they could say, here's the circumstances in which I would want a message like that to be sent, and we can automate that so it, again, feels like a direct message, the physician would know that that has been sent, but it's not necessarily taking time out of their life to do that. So that's one thing. Social determinants of health, another really important thing that I think we are going to be layering in over time. And then, it becomes a question of what do we do with that data, right? And so having this integrated model, because we are, a standalone digital solution, so we're not going to know that, in your particular neighborhood, there's this organization that has this program that, we won't have that depth of integration, but certainly where, there's a care center, located in the patient's area, we could send that as a piece of information along that this issue came up, and therefore, in your next engagement with the patient, this is a topic to discuss. So yeah, absolutely, this is all stuff that I think is on our roadmap to do. And then I will say the other thing is the scalability component is really important. So we, as a digital solution, we've got about 150 patients, That's very, very, very small for us and what we do. We have a different program we haven't talked about here, which is, diabetes prevention program. We enrolled more than 30,000 people last year. And, I think we had to spin up 1 or 2 more servers. So its scale is what we deliver, but we want to make sure what we're delivering at scale still at the individual level is driving those, meaningful engagement and outcomes. So it feels personal, and it doesn't feel like I'm one of 30,000, but I'm one of one. So that's very important in our design.
Yeah, the other, to the kind of your second part of your question around kind of the group model, and Kevin touched on that a little bit. We have done, when I mentioned the virtual diabetes prevention program, that program's now called Real Appeal and has scaled. It does have a group component where you would kind of do a group online session as well as individual coaching. So that has been talked about, is how would we integrate that into the model? And we have had a patient that asked, where's my group that I go talk to, the, people that are like me, in addition to the coaching. So that is something, when we talked about the pilot, we had to make some tough decisions. That was in scope at one point. And, we had to dial back to kind of what we call in the business world MVP. So minimally viable product. And so that was not in scope for phase 1, but definitely something we want to talk about and look at for phase 2.
And Doctor, will you have any comments with respect to the caregivers? Since, dealing with the pediatric patient populations, you do incorporate caregivers into the pilot.
If you can just rephrase that question regarding this.
Just incorporating caregivers into our pilot.
Yeah, Kevin and I were talking about this beforehand as well. I am someone that would love the ability to, opt in to send my teen a message when they, had a day where their glucoses were in range. I mean, that kind of pat on the back goes a long way. And if there's a, efficient way to do that in my workflow, I think it would just be absolutely fantastic, especially for the teenagers. I mean, this WellHop has focused a lot on, 18 and older, but I think there's a very needy and a patient population that would just benefit so greatly from this type of intervention in the adolescents. I think they would just really, do well with this. So I'm excited when it kind of migrates down to the younger ages.
Hi, Colleen McGuire, Silver Fern Healthcare. I'm curious if you can talk a little bit about essentially what drives the responses from the AI. I mean, what is the database that, because I was looking in it and there was the dialogue about breakfast, glass of orange juice and frosted flakes, and I'm like, They said the first response was, that's a pretty good meal. And I thought, and then it says, oh, it's too much sugar, but, so where does that come from?
Yeah, so one of the challenges we have is, so we use a lot of CBT, so cognitive behavioral therapy, and what you don't want to have is a nagging app, right? You don't want to have the red badge, that's bad, because guess how engaged they're going to be long term, right? It drops off pretty quickly. So one of the examples I give, and yeah, as someone who knows about nutrition and stuff, it makes me cringe a little bit, but I love the pizza with tomatoes on top. We're going to give you some credit for the fact you put a vegetable on top of a pizza, right? Over time, we're going to be a little more strict about it, but it's, we take a long-term view, and so, it really is, when we talk about the AI, it's about serving up conversations that will drive long-term engagement, because where we see long-term engagement, we see really clear evidence of positive outcomes, right? And so it's how can we take that one piece of information about the thing that you're doing that is like, okay, this is something I would change, without having it be a onslaught of you're doing a lot of bad stuff. So that's kind of the balancing act of, how do you get someone to do something different without telling them what they're doing is necessarily bad.
Does the AI think that ketchup is a vegetable?
What was that? Sorry. Oh, ketchup and vegetable. God, I hope not. I don't believe so.
But if I can just follow up.
Sure.
Quickly. I'm thinking in terms of, we were on this low fat forever,
Mhm.
and now we're not on low fat, right? I mean, so we keep changing what the pyramid looks like in that. So what's driving those responses?
Yeah, so in terms of the actual like food system, so we have nutritionists on staff. We built out our own custom food server. We've got, I think we're up to like 32,000 meals and ingredients, and we haven't spent a lot of time on it. But the food, I mean, it's really, really dynamic to the point where we every single day give a report on 12 different things: sugars, carbs, calories, fruits, vegetables, and on every single one of those you can click and it'll give you, green, yellow, red of where you are in range, and we actually adjust your standards for your personal health, so your height, your weight, your BMI, and we change it. So if you were, if you lost 20 pounds, guess what? Your nutritional recommendations have also changed, and we do that automatically. Yeah.
Good question, thank you.
I'm actually Jake Pasquale from SMC Partners. I have another question about the application. So
Sure.
when the user is communicating, are they given prompts of what to answer, or do they have
Yeah, so it's a mix. So mostly what we do is predetermined prompts with options and choices, right? Yes, no, I'm not sure, some version of that. We want to avoid the Siri problem, which is, I ask and here's what I found on Google, because then you're just basically a Google search engine. And we also don't want to go down the rabbit hole of WebMD of, great information, but, everything you read it and it's, guess what, I think I have cancer, no matter what my symptom is. And so we want to keep it, in a swim lane that's meaningful. So what we do is, we'll take the data to serve up the conversation that we think is useful and basically give them choices within that allow them to have the conversation they want. We do have free form text input, so food is the most obvious. People record their meal and we use NLP, natural language processing, to decipher and pull out what those elements are. So you can do something complex and say, every ingredient you had in a meal, or you can say like, I had a burrito. And we'll have assumptions of what that is, and then people can add to, change serving sizes, things like that. That's the most common free text place. We also do emotional free text. It's fairly light right now because that can go a lot of very different ways. But we'll do things like, I noticed today was, a little bit of an off day. You were, more out of range. Can you, what's the one thing you want to do tomorrow that will put you in a better position of control, for tomorrow, giving them the opportunity to respond there. And then, we give them kudos on just thinking about it is already a step in the right direction. Whether they act in it or not, hopefully they do, but just taking the minute to think about it is something that should be acknowledged.
Thank you, Kevin. I know we're bumping up against time, so I want to give our speakers any final comments before we wrap up.
Go ahead, you can have the final.
Well, thank you. As you've heard from these speakers, we're quite passionate about what we're doing, and it's really about taking care to the patients, not waiting for the patients to come in. That's why we're excited, and we've taken this more innovative step in our approach to care, because I see tremendous opportunity to expand it beyond type 2 diabetes to other chronic care illnesses, and hopefully as well to other patient populations. As we talked last night, I think it would be very critical to extend this to the pediatric patient population. Then you could stop it there so it doesn't continue to progress as an adult. So thank you very much for your time, and thank you very much for the time that you're putting into our pilot, because I think it's really going to change care delivery in our market and bring better care to our patients. So thank you.
And I'll just add my thanks to the team. Fantastic job. And so we're getting you out right on time, so I think we have about half an hour before the next, I think it's lunch is after that. So please do go check out the posters. The students and residents will be coming in as their schedules allow over the course of the day. So if you go at different times, you'll probably see additional ones as the day goes on. So please check it out. Thank you.